Good evening. It is already 8:02 and we really need to start the meeting. I want to take this opportunity to welcome all of us to this special webinar in recognition of the International HPV Awareness Day that is usually celebrated every 4th March every year. We appreciate your time and commitment to learning more about this crucial public health issue. My name is Florence Akech. I'm the County Chief Nursing Officer of Kisumu County, and I'm honored to be your host and moderator for this session today. We have an insightful discussion ahead that is featuring expert perspectives and key takeaways to help us contribute to HPV awareness and prevention in this country. I take this opportunity to appreciate the NNAK for giving us this platform today to talk about our cervical cancer. We also appreciate the partnership that NNAK has had with Capricorn in supporting webinars in this platform. Today we are here to talk about an important yet often misunderstood topic of the HPV virus and cervical cancer, how it is prevented, and the screening and vaccination strategies. HPV is one of the most common infections worldwide, yet many people do not realize its impact. The good news we have today is that cervical cancer is one of the most preventable cancers, and thanks to the advances in vaccines and early detection. As we start, we'll share some of a few housekeeping rules. The webinar will last around 1 hour. We encourage you to stay engaged. Feel free to drop your question in the chat box that we'll be able to address during the question and answer session. The recording is on, and those who miss any part of the session may be able to get it later. Now it's my privilege to introduce our distinguished speaker today, who is Sela Owuor. She is our NCD screening and cervical cancer lead in Kisumu County. She has extensive experience in cervical cancer management, a deep passion in HPV awareness and prevention, and Sela has been actively involved in improving cervical cancer screening in Kisumu County. We are truly honored to have her in this session today to share her invaluable insights on cervical cancer prevention strategies. Please join me in welcoming Sela to this session this evening.
Thank you, Florence. I've been introduced by Florence Sela Owuor, as we have been told. So I would like to take us through cervical cancer prevention strategies. Given that this is the HPV awareness, today is the International HPV Awareness Day, and the entire week we shall be creating awareness on HPV. And so we can't talk about HPV without talking about cervical cancer. So my presentation outline is there. You can have facts about cervical cancer, risk factors for cervical cancer, people burden, the Kenyan situation. We will look at the policy framework, particularly in Kenya, then cervical cancer prevention, the key perspectives, and the call to action. So cervical cancer is caused by long-term infection with the human papillomavirus or HPV. And only high-risk types of HPV cause the cancer, mainly type 16 and 18, which cause about 70% of cervical cancers globally. There are, however, 15 high-risk oncogenic types or subtypes of cancer of HPV, but the main ones are type 16 and 18. So HPV is a common sexually transmitted viral infection among men and women, and the lifetime risk of acquiring HPV in sexually active women is 86% by the time women reach the age of 50. So out of the entire population, 86% will have acquired HPV infection by the time they reach 50 years of age. However, most HPV infections do not cause any symptoms, and most people actually never know that they are infected. In most cases, HPV infection clears on its own from the body's own immune response. So some HPV infections actually may not clear and will become persistent. And this persistence is what now causes cancer in the cervix that can later develop into cervical cancer. So it's also important to note that HIV-infected women have 6 times or more risk of cervical cancer than those who are not infected with HIV. And it occurs about a decade earlier and is more aggressive in HIV positive women. The good thing is that infections or co-infections, STIs such as chlamydia can be a high risk factor for contracting cervical cancer. Poor immunity due to HIV/AIDS infection, use, having multiple sexual partners, and also having sexual partner with multiple sexual partners. Then also early sexual debut or engaging in sexual activity at an early age. So the global burden of cervical cancer, if you look at this map here, it's in blue. So the darker shades actually indicate a very high prevalence of cervical cancer. And you can see that the most affected globally is actually Africa and maybe South America and maybe parts of Asia, but they're not as bad as Africa. And you can see where Kenya is, maybe East Africa, and even many parts of the southern part of Africa and even West Africa. So cervical cancer is number 4 cancer in women globally, and about 570,000 new cases are diagnosed each year, with 311,000 deaths again happening every year. And 90% of these deaths are in less developed countries, such as our own country, and the highest rates are actually in Eastern Africa. So the more concern for us to try and change this picture. So the burden of cervical cancer in Kenya actually, 9 women die from cervical cancer daily, every day. So if you were to calculate that one, we can see how many would be dying maybe from every county if we spread it. Yes, that is the situation. And it is the leading cause of cancer deaths among women in Kenya. It mostly affects women aged 35 to 49 years. This is the most productive age for women. These are our mothers, they are our sisters, wives, they are us women who suffer needless deaths from a cancer that is actually preventable. So despite all this, there has been an improved in screening of women aged 25 to 49 years, from 5% in the year 2018 to 30.3% in the year 2024. However, this is still considerably low given the national targets of 70% screening for women with a high performance test. So only 33% of these women who had a positive screen test, regardless of the screening method used in this case, received treatment. And this is also still very low, as we shall look at the national targets for treatment, which should also be 90%. So we are still lagging behind at 33% treatment. This is according to the KHIS 2024. So in 2018, there was a global strategy to eliminate cervical cancer globally. And this was launched in 2020, November. And there were targets which were to be achieved by the year 2030. And the vision was to have a world without cervical cancer, the long-term vision. So these targets were actually that 90% of girls aged 10 to 14 years are fully vaccinated with HPV vaccine by the time they reach 15 years of age, and they should have gotten 2 doses of HPV vaccine. Then the next target was screening, and the requirement is that 70% of women are screened with a high performance test by the time they reach 35 years of age, and again by the time they reach 45 years of age. And it is actually, research has identified that if a woman is screened even once in their lifetime, then their chances of getting or of suffering cervical cancer is reduced by 60%. So if they are able to get it twice, the screening twice with a high performance test, then they are good to go, and they're safe and almost maybe free from cervical cancer. The third target is that of those women identified with cervical cancer disease, because during screening, we will find those who already have invasive cancer. So these women, the requirement is that, or the target is that these women, 90% of them with precancer are treated, and 90% of women with invasive cancer are also managed appropriately according to their diagnosis. So we have the life course approach to cervical cancer prevention and control. And we have primary prevention. I've talked about this. It's about HPV vaccination for girls aged 10 to 14 years. It's also important to note that we are moving away from these 10 to 14 years and the 2 doses, and we are going to a single dose for girls aged 10 years. So this vaccination, currently in Kenya, we are giving it to girls only, is appropriate, of course, with the ages that I've mentioned. And alongside the vaccination, the HPV vaccination, you also give health information and warnings about tobacco use, about prevention, sexuality education tailored to age and culture, condom promotion, and provision for those engaged in sexual activity. And this involves actually boys and girls. When we do health education in schools or to targeting the young adolescents, we actually include boys in these messages because they're also crucial here. Then we also have male circumcision, which we are promoting as a prevention for HPV in boys. Then secondary prevention, this one is targeting women aged above 30 years and above. For our case, programmatically, in Kenya, we look at 25 to 49 years for screening. And here we are promoting the single visit approach for screen and treat, where we screen, and mainly in most of our facilities, nearly 100% that offer any cervical cancer screening, they are able to do via a visual inspection with acetic acid. And if there are lesions, then we are able to treat during that particular visit. Then there's the point of care rapid HPV testing for high-risk HPV types for those facilities or for the outlets that are able to do this. Like in Kisumu, mainly we do it in during outreaches for self-testing with HPV, then followed by immediate treatment, and also we have on-site treatment. But we also use the primary care networks in terms of treatment. such that we may, because we don't have adequate treatment devices everywhere, so we use the primary care networks. Maybe I'll talk about it a little bit later. Then we have tertiary prevention for all women as needed. And this is the treatment of invasive cancer. Uh, uh, and here we have ablative surgery, thermoablation or LEEP, or the large loop excision of the transformation zone. We have radiotherapy, we have chemotherapy, and also we have palliative care as appropriate for individual women. So for the global strategy, for us in Kenya to implement this, we have cancer policy documents, which you can see displayed here. We have the Kenya Cancer Policy of 2019 to 2030. Then we have the National Cancer Control Strategy. This is also a second edition. This is 2023 to 2027. Then we have the National Cancer Screening and Early Diagnosis Guidelines. It's also a very recent one, second edition, 2024. Then we have the National Cancer Specimen Handling Guidelines of 2020 and the National Cancer Treatment Protocols of 2019. And the good thing that these are all available online and you can access them simply by Googling. So we also have barriers for cervical cancer prevention in Kenya. And these barriers are maybe classified into individual, provider, or facility factors, then systemic factors. So we have, as individual factors, we have low HPV awareness, particularly in rural and uneducated or semi-educated groups, where people do not know much or a lot of information about this HPV and cervical cancer and all. The awareness is it's everywhere, even in urban areas, but the low awareness is more prevalent in the rural areas. Then there's the poor understanding of HPV and cancer, cervical cancer link. Sometimes we have done this mass self-testing for HPV, and the outcome usually is that women fear. When sometimes people are not able to differentiate between having, if you tell them they are positive for HPV, there's a lot of education and really a lot of information that you should share to separate HPV and because some of them believe that HPV means that you are already have a diagnosis of cancer. So that one is a barrier because people fear. We have cultural issues, myths and misconceptions about cancer, and even stigma. There's a stigma about cervical cancer, especially given that it is also sexually transmitted. But we know that is actually the main mode of transmission. But we know that it is also transmitted through fomites and also vertical transmission from mother to child. So these myths and misconceptions, some of them are really outrageous, but they are actually barriers that we must address if we are to change the current situation. Then there's the fear of screening. People feel that maybe it is painful, their privacy is being invaded and such like things. And sometimes just fear of even knowing that they might be having cancer, or that they may be having cervical cancer lesions. So those fears are also there and a big barrier to prevention. Then there's just generally poor screening uptake. People just don't maybe want to go for screening because probably a woman feels that maybe she's a small scale trader or doing some business or small scale farming. And the time she's not in pain anywhere, she has no symptoms whatsoever. So screening for cervical cancer is not really a priority most of the times. And we find that for those, researchers also identified that those women who are screened every year. They are the ones who keep on going every other year, they are the ones who get screened repeatedly. And this should not be the case because we know the screening intervals, how they should be. So then there's just the low HPV vaccination coverage. Yeah, of which we know in Kenya we have not done so well so far, apart from maybe the year 2021 when we had mass vaccination outreaches for HPV, and we were able to get, but otherwise programmatically, it has not been so good. Then also compromised follow-up. When we screen and women turn out to be maybe positive for VIA or for HPV, our main screening tests, following them up is quite an issue. We have we have quite a number of women who may test positive, but then you give them a call to come back for treatment or follow-up. Initially, the response has not been so encouraging, and our systems have not are also not been so well developed to be able to follow them up. Sometimes, of course, they give wrong phone numbers, so you follow up and you don't get the person that you need. So you don't know what happens to this woman or what will happen to them in the next few years, and especially for those who are even HIV positive. Sometimes they may have lesions and even develop invasive cervical cancer within a very short time. So that one is also a challenge. Then we have provider and facility factors, human resource shortages. These are, I think, cross-cutting everywhere in the country. Training and education. In 2020, between 2019 to 2021, we had a very huge number of about 1,000 people, service providers, who are trained on see and treat for screening and for screen and treat of cervical cancer. But again, 1,000 for the whole country is quite a drop in the ocean. It wasn't. It was good. Yes, it was good. We've seen impacts, particularly in counties where these people were trained, because they were not trained in all the counties in the country. It's now that other countries are picking up the training. So, and even those who are trained, of course, usually there's natural attrition, redeployment, and all that. So training and education and mentorship remains a challenge, because cervical cancer is a skill that really needs keen follow-up and mentorship for service providers to be continuously competent to offer it. Then the issue of commodities and equipment for screening. Here we are talking about screening with a high performance test, and in this case, HPV, or even cytology for those who are below 25 years or below 30 years. But it is not within our reach. It's quite costly. For example, in Kisumu, I know even in Kenya, there are just a few facilities in every county that are able to do cytology. In Kisumu, in the public sector, we are only able to do it in JTRH, but also at a cost, because to make it a little bit sustainable, though the cost is highly subsidized. But even for doing commodities for doing screenings like visual inspection with acetic acid, issues of gloves, particularly disposable speculums, yes, and even cotton wool, all those things that we need to screen for VIA. It's quite a challenge. And HPV screening, we have been able to roll it out only with the support of our partners. So that remains a challenge. And even the equipment like the thermal ablators and lip machines. I know most of our country, most of our facilities don't have them. In Kisumu, we have 42 treatment facilities that can offer cervical cancer treatment, 42 out of 211 who offer screening. So you can look at that disparity, and we have to refer or network in order to treat our patients. Then and that is treatment with thermoablation. But with LIP, the county hospitals, although those who are trained again because of attrition, everyone left. So we need also trainings on those areas, see and treat, uh, uh, lip and all that. Then poor referral systems and patient navigation. Referral systems is left upon the patient and the service provider. Again, not very well streamlined. And patient navigation, we mostly when we refer our patients, particularly for maybe biopsy, they have to go to, or cytology, they have to go to our main referral hospital, Jaramogi Oginga Odinga Teaching and Referral Hospital, also known as JOTRH. But when they go there, they have to know which day to go. They will need some money for registration. So all those dynamics make it very difficult for patients. They create a barrier for this prevention, and the patient may go back home or may not even have transport to travel. And all these actually act as a barrier to the prevention of cervical cancer. Because if they were able to go immediately, the outcomes would definitely be better. So advanced therapeutics, chemotherapy or radiation. So not again, these are services that are offered in select facilities. They are not so commonly available. Yeah, in Kisumu, the public facility that we have is just JOTRH, but we have several private facilities. Then, of course, also palliative care. All these patients, most of these patients need palliative care, those with invasive cancer. But again, palliative care is not so available in most of our facilities. Then we also have systemic factors, access to healthcare. Like now, when the patients have to be to have their samples for biopsies may be tested. We know that previously NHIF has not been covering this um, uh, what investigations or diagnostics. Yes, and also the health inequities, the poor, the uneducated, those living in rural areas may also not be able to access some of these diagnostics very easily. And we know the challenges that we have with SHA currently. So access to healthcare and also an insurance. Some of our patients that we see now are not even able to get screened because SHA covers this cervical cancer screening. But some of our patients don't even have women, young, especially the younger women. They don't even have identity cards. So it makes it very, very complicated for them to access even this care. Then poor reporting, surveillance, and tracking systems. Yes, issues to do with with reporting. Yes, and even tracking of this. It's now that the cancer registries are being strengthened, like particularly the one is in Kisumu is being developed and strengthened at the same time. So for us to get valuable information or reliable information about cancer, all cancers generally. Then poor monitoring and evaluation, supervision, target setting. Most facilities to date, people are not very well informed about their targets for cervical cancer screening and even performance indicators. When it comes to cervical cancer, what indicators are we supposed to monitor? Which ones are we supposed to look at to know if we are on track? So this is also a barrier. And then quality improvement issues. Yes, quality improvement issues. Things keep on changing every day, but we are trying to integrate this cervical cancer into our quality, but we have quality issues around it. Even if we're using acetic acid, how do we use and all that? So we have the call to action to support the elimination of cervical cancer. So we are called upon to be champions for vaccination, screening, and treatment. And not only that, to go beyond and even in terms of treatment, follow-up, referral, and all. So avail organized screening services in health facilities to complement opportunistic services. So there are many opportunities that we can take advantage of to increase our uptake for cervical cancer screening, so that we ensure that everybody, maybe all women who come to the health facility, they are offered this service and they can actually get it. Then also to offer health education to clients, communities at every opportunity. And this from households, right from the household to any various community forums and any opportunity, chamas, churches, and all. We give health education about cervical cancer to these clients. Then also to screen all eligible women and rescreen at appropriate intervals. Yes, all eligible women. And here we screen all eligible women is any woman who has ever had sexual intercourse, and rescreen at appropriate intervals, depending on the type of test that is being conducted for that particular woman. Then ensure proper follow-up, linkage to care, and appropriate referral. Follow-up, for those who turn negative, we give them the right return date. Then for those, particularly those who turn positive also, those are the biggest challenge when it comes to follow-up. So we need to follow up very keenly. Then linkage to care and ensure that they go. There are organizations that are working with these clients, even on patient navigation, to help make the process of treatment and linkages much easier and encouraging, so that patients are encouraged to keep on coming for treatment. Then ensure availability of commodities supplies for screening. This is a big challenge, and I know it cuts across, but also it takes interest of a particular maybe county for that matter. Kisumu, I would say we are not perfect in terms of commodities either, but we have a lot of political will and good political will and support. We all know that our governor is a survivor of cancer, prostate, which is in the public domain. And so for that reason, he's a champion also for cancers, including cervical cancer. And the first lady is the patron cervical cancer in our county. And also the CEC is an OBS gyne oncologist with a lot of interest in cervical cancer. So that supports us. And counties like us who have that kind of support, it's important. And it helps a lot to push the agenda of cervical cancer elimination. And then we also asked to involve and engage communities as agents of change. Anyone can be an agent of change, right from yourself as an individual. And being an agent of change also means if you're a woman, or we all have women in our lives, even if we are not women, getting screened yourself, getting your girls or the girls that you know around you, uh, uh, getting vaccinated, and then getting screened, and also getting treated for those who are found with invasive cancer. So that is what we had. That is what I had for us. And
what an insightful session that we have had today. Thank you, Sela, for giving invaluable information to our audience. We have shared about cervical cancer, the facts, the risks, the global burden, the Kenyan situation. We have also had the policy framework and the cervical cancer prevention strategies, some key perspectives on call to action. And we now open it for us for any questions. Feel free to share can allow you to ask any question. You can raise your hand in the hand button so that we give you an opportunity to ask any question. I'm checking on the chat box. Yes. Somebody talking on the background? Feel free to ask questions in the chat box. I can just see comments of good presentation. There's a comment on need to strengthen treatment for the lesions. Somebody has said, Mark Simia said, I didn't hear about how the patient with cancer, cervical cancer presents. Maybe you'll be able to share that. Thank you, Sela. Kindly talk about integration of breast cancer. Thank you for the wonderful presentation, though I joined late due to unavailable. I would really appreciate if you can share the slides. Yes, we'll be able to share that. If you are screened, another question from Lillian Machoma. If you are screened negative for HPV, can you be vaccinated even if you are older than 14 years? Is there age limit for screening? Elizabeth Akinyi is asking why is cervical cancer most common in the elderly? Elaborate on that. Can we do HPV test only those who are positive, or we can also do it to those who are negative? Thank you. We can start by answering that as we look for more questions.
Yes. Thank you for those questions. Somebody has asked about signs and symptoms of cervical cancer. And I also want to say that there are symptoms which I'm going to mention, but also we have come across people with invasive cancer without some of these or suspicious for cancer without any symptom, no pain, nothing whatsoever. But the symptoms that I can talk about, there is a bleeding, vaginal bleeding can be there. Then usually painful intercourse is normally almost purely diagnostic about cervical cancer in women. Then there can be low abdominal pain. And we can also have some other symptoms like nausea, these general symptoms, but the very specific ones be low abdominal pain and backache, vaginal bleeding, and also painful intercourse for women. On integration of breast cancer, thank you very much for this question. I just thought we didn't have enough time, but in as much as I'm a cervical cancer lead, we actually integrate breast cancer screening in our while screening, because there's no point of screening a woman for cervical cancer only to later have the woman getting diagnosed and probably dying or getting sick of breast cancer. So we do this, and the uptake for breast cancer screening has really improved in the last few years, maybe 3 years or so. And we encourage that for every woman that we screen for cervical cancer, let us integrate breast cancer screening. Clinical breast examination is done annually, and you can teach the women to do self-breast examination also annually or after they experience their monthly period every month. And we also have mammography for women aged 40 years and above. And of course, I know there are not many facilities that are able to do this, and also breast ultrasound. But clinical breast examination is good and can really filter and help identify those breast lumps early. So please let us integrate breast cancer into our cervical cancer screening programs. Then somebody asked if HIV, can you be screened if you are HPV negative? Can you be screened if older? What was the question? No, not that one. There's another one. Okay, let's just go down. I don't know if. Why is cervical cancer most common in the elderly? We say that it can take about 10 to 15 years for somebody who has been having persistent HPV infection. So if somebody got that HPV infection, because women are sexually active maybe at different points in their across their lifetimes. So depending on when somebody actually got that infection, they can start now have invasive cancer in their late years, and that's why probably it's most common. I wouldn't say that it's common in the elderly, but we say that between 35 to 49, that is when it hits hard for most women. But in the elderly, it is also possible. Maybe they got the infection early, but it is manifesting late in their lives. Then have you encountered any cultural or religious barriers to screening? I think I mentioned maybe some of them. Some of them. Of course, there are those religions that just believe, don't have a very positive attitude towards health interventions. Those ones is particularly vaccination also, but even screening, and there are those that fear people fear the issue of privacy, and it is closely linked to maybe religion, cultural barriers. People feel that cancer is not really cancer; it is a curse or something else, but not cancer. So this one we mainly just address it through education and sensitization, and just through talking and more information sharing. Yes. What are the plans of our county to increase the number of women treated from 33%? What are our plans? The plans, I talked about maybe the barriers. The plans generally is just to continue advocating to get more supplies. And even as we do that, women also need to, if women were able to come for this screening, I'm sure if they came to our facilities, particularly maybe for example, Kisumu, we would be able to reach this, as we have gone beyond 33%, by the way. Kisumu, I think in the last 2 years, but this was a national figure. So it's just about information, giving to the community and promoting this health-seeking behavior about cervical cancer screening, and also being ready on the health system side to be able to provide that service to clients when they come, so that the supply meets demand or demand meets supply in that case. What is the government doing in promoting access to treatment for auspicious and confirmed cases? Wow, this is a difficult one. But if we look at the policy documents that I shared, maybe you can look at them, have a look at them later. and see what the country is doing to increase access to treatment for these cases. Like in Kisumu, the county is working towards the strengthening and the development of a comprehensive uh, cancer center. We know recently, was it last year or maybe 2 years ago, we have one in Nakuru. And many counties are coming up with these comprehensive care cancer centers. What is the first line treatment for cervical cancer? Depending on the staging, if there are cervical cancer lesions, then we do screen and treat. Again, I will refer us to the algorithm. We are trying to manage time, but we can look at the algorithm for treatment of for cancer. But again, it depends on the staging. For women who turn HPV positive, we have colposcopy for them. And if we don't have colposcopy, we do VIA, then we can do thermoablation.
Wapi?
Somebody is talking. Yes, depending on the staging. So please I'll refer you to the algorithm to look at that. It's worth noting that by the time you have any of the symptoms, it is too late for any of the management options. So prevention through vaccination and regular checkups are key. Thank you. Yes, Robert Carrier. Serfin, the new strategy to administer HPV vaccine only once. When is it starting, and how about the HPV plus strategy for HIV infected girls? For how many doses?
Thank you so much, Seraphine. The HPV single dose has already been launched, and we are waiting for the deployment from the National Vaccine and Immunization and the official rollout. For the HIV-infected girls, they get 3 doses. I think our time is well spent, and we are happy with the comments that we are getting in the chat box, and some of them are compliments. Thanks for the presentation. How can we assist the client 59 years old? Received this text. Hello, Sally. Hope this finds you well. The HPV you took is positive for HPV 16. Positive results does not mean you have cancer, but it means you have high chances of developing cancer. If not treated, kindly visit any facility that have a treatment device to receive a checkup and possible treatment. Sela, when they get such a message, what would you advise?
Usually these are women who have been screened before, and this message is from the Emergency Operation Center number. It is toll free in Kisumu. So if they have this kind of information, if they have this kind of message, then they need to either call the EOC toll-free number free of charge for clarification, or go to the nearest facility. Usually they can go back to where they were screened, or the nearest facility to where they were screened. But they can call the EOC line toll-free and get more information. There was somebody asked about the age limit for screening. There's no age limit for screening, depending on the test that is being conducted. If it is cytology and HPV, we can go up to even 65. I've seen some organizations even going up to 70 years screening. And we said the eligibility criteria is any woman who has ever had sex. So this one we will go down into which test, and specifically in every individual, because this is specific to every individual and the test that is being conducted. Somebody asked a question about, can we do HPV test to those positive? It is not very clear. Can we do HPV test or vaccination to the positive, to those? It wasn't very clear, and I think we've lost it. The cost of vaccine, it is free in government facilities, and it is a free vaccine. And somebody asked if we can vaccinate.
Currently, we are even reverting to the 10 years old with the new vaccine, with the single dose vaccine. The 10 to 14 years was a strategy to catch up the girls who had missed the vaccination during the COVID period. So for now, we are currently vaccinating 10 to 14 years with the 2 doses. But once this is rolled out, then we'll be vaccinating the 10 doses. We're just waiting for the communication on this. Otherwise, the vaccine is free in our facilities. And once you are vaccinated, somebody has asked, you get a certificate. Once you are vaccinated, there's a vaccination card that is usually provided to the girls that they carry with them that shows that they have already been vaccinated. I think time is well spent, and we may not take more questions. However, we really appreciate that you were able to attend this meeting, attend this very interactive session. So today we have learned that HPV-related cancers, especially cervical cancer, can be prevented, but awareness and actions are very key. Somebody, just as I finish, somebody has asked what about the frequency of screening for negatives?
Yes, boys can be screened. Like I would give an example of Rwanda. Rwanda is currently screening boys because they have done very well in screening girls. But for Kenya, we have not even managed to screen the girls who are the main target. But it is a good thing to also screen the boys to also prevent penile cancers and also esophageal and brain cancers. What about the screening for negative cases? Please, I refer you to the protocol. Look at the protocol, Google, and just find it because of time. Please, yes, thank you.
Yeah, so before we wrap up, we just need to remember 3 key takeaways. One, HPV vaccination is safe, it is effective and recommended for both girls and boys. However, Kenya is still implementing the girls as we await for implementation for the boys. However, there are countries that are already vaccinating girls and boys like Rwanda, just as Sela has said. Number two, regular screening can detect HPV-related changes early, preventing cervical cancer. So we should go for HPV testing for to be able to identify any changes that are related to cancer. Number three, talking openly about HPV and educating our communities can help break the stigma and can save our lives. So if you found today's session very helpful, share what you've learned with others, and together we can move closer to a world where HPV-related cancers are eliminated. Thank you for joining, and let's continue this important conversation beyond today. Let's stay safe. The institution has been accredited for CPD points, so you're able to get this in the chat box. So we're going to allow you time so that you are able to uh, upload this so that you're able to gain the CPD points. Otherwise, thank you so much for attending. I know it is late, but you decided to attend the meeting. And please share with the others what we have been able to share. And I'm your host. I've been your host, Florence Akech, and Sela Owor has been the presenter.
Thank you very much for attending and listening. Have a good night.
Thank you.